Our objectives this morning, or this afternoon actually, are to talk about three things. Number one, we're going to talk about diagnosis of bone tumors by looking systematically at some discriminators or findings that help us narrow the differential diagnosis. We'll also talk very briefly about what you need to know about staging of tumors, and then really focus in on the classification of bone tumors into 6 categories. First, with respect to the diagnosis, using discriminators or findings that we look at in every single case. They include the patient age and lesion location. We also always look at the pattern of bone destruction, the tumor matrix, and the tumor extent. So let's go through these one by one, starting with patient age. Not just in love, but also with tumors, timing is everything. Very briefly, we'll just run through what each of these look like according to age. First, in the young pediatric patients, 1 to 15 years, we're going to be thinking about the possibility of Langerhans cell histiocytosis because it's easy to forget about. A little bit older, 5 to 30-year-old age group, bones very active, a lot of things in the differential, both malignant and benign, malignant osteosarcoma, and also malignant Ewing sarcomas. We'll talk more about these in great detail. But also a number of benign lesions. Non-ossifying fibroma, or when less than 2 cm of fibrous cortical defect. Also, solitary bone cyst, like we see here. An aneurysmal bone cyst, like we see here. Fibrous dysplasia, that we'll talk more about in detail. And then this lesion that we see in the epiphysis of a kid, chondroblastoma. With advancing age to young to middle-aged adults, 20 to 50 years, giant cell tumors of bone occur. Over the age of 30, we need to start thinking about chondrosarcoma. And then over the age of 40, by far statistically the most likely are METs and myeloma. Okay, so that's a quick overview by age. What about lesion location? Location, location, location. There are only so many things that affect the diaphysis of a long bone. One of them being Ewing sarcoma. You can see this aggressive bone destruction with adjacent soft tissue mass. In the metaphysis, an active area of bone, there are a lot of different things in the differential that we'll talk about, including non-ossifying fibroma, osteochondroma, and the sarcomas. And then in the epiphysis, the differential becomes quite narrow again. Namely, we think about a subchondral cyst most commonly when we see something that looks like a cyst. But if we see a lesion in the subarticular bone that looks low in signal intensity on T2 weighted images, we'll think about a chondroblastoma in a skeletally immature patient. And when it involves both the epiphysis and adjacent metaphysis, we'll think about giant cell tumor of bone. Okay, patient age, lesion location. What about the pattern of bone destruction? Well, that's important because it reflects the biologic activity or growth rate of a lesion. So we talk about lesions being aggressive in appearance if they have a permeative or moth-eaten pattern of bone destruction, with a zone of transition that's wide and a lesion margin that is non-sclerotic, as in this case of a lymphoma of bone. Non-aggressive lesions, on the other hand, are characterized by a geographic well-defined border with a zone of transition that's narrow and a lesion margin that is sclerotic, as we see in this case of a solitary bone cyst. So we've talked about patient age, lesion location, the pattern of bone destruction, and then of course we look for a tumor matrix because this helps us classify the tumor by tissue type. The classic types of matrix, of course, include osteoid matrix, described as ivory, fluffy, or cloud-like matrix, like in this osteosarcoma, or chondroid matrix, such as these calcified arcs, rings, punctate, or stippled calcification that we can see in a chondroid lesion. And then this matrix, what's this one? Well, this, of course, is that ground glass matrix, that hazy opacification in a lytic lesion characteristic of fibrous dysplasia. Now, we've talked about patient age, lesion location, pattern of bone destruction, and tumor matrix, but we also have to consider tumor extent. And one way of doing that is by looking at whether the bone is involved at one place or whether there are multiple places in the skeleton that are involved. because if you see multiple lesions, that helps you narrow the differential diagnosis. Some people use the mnemonic FEMI, F for fibrous dysplasia, E for EG and chondroma, M for Mets and myeloma, H for multiple brown tumors in the setting of hyperparathyroidism, and then we must not forget about I, infection, which is a much different condition in terms of management. And then when we have gone through those systematic discriminators, we want to report that concludes what we think is going on. We need to commit and synthesize our findings. So do we think something is benign, such as this don't touch lesion, a non-ossifying fibroma that should not be biopsied and needs no further workup? Alternatively, we might conclude that the lesion is almost certainly benign, such as this case, where follow-up radiographs may be appropriate. That may be the case with fibrous dysplasia or in a case like this of heterotopic ossification. We may also conclude that we're dealing with a benign symptomatic lesion. Surgery may be indicated in cases like this, such as curettage and packing. These types of lesions include giant cell tumor of bone, chondroblastoma, and in this case, a solitary bone cyst that was packed. Another conclusion that we may come to based on the imaging findings is that we don't know what's going on. We don't know whether it's benign or malignant, and we try to keep this group small, but we realize that many of these patients will need to go on to biopsy, as in this case of a patient who had myeloma. Finally, we may conclude that the appearance is malignant until proven otherwise, such as with this osteosarcoma, with an aggressive sunburst pattern of periosteal reaction. What about staging? Well, very briefly, what you need to know is that there are three variables that go into staging of musculoskeletal tumors. There's the histologic grade, simply whether it's low grade or high grade. There's the local tumor extent, whether it is confined to the compartment of origin or whether it is extended beyond that. And then finally, whether or not there are metastases. So three basic variables: histologic grade, local tumor extent, and metastases. And the concepts that get taught again and again are very broad and important. Stratify the patients into groups for prognosis and treatment. That's why we do staging. It's a multidisciplinary effort that involves radiologists and non-radiologists, and that ideally, that biopsy of primary bone lesions should be performed at the institution doing the definitive treatment. So what about classification of tumors? We'll focus the rest of our time on the actual diagnosis by tissue type, looking at lesions that either look like they come from bone, cartilage, fibrous tissue, vascular tissue, marrow, or some miscellaneous tissue. So whether you're a pathologist or a radiologist, we're all trying to do this. With respect to the bone-forming or osteoblastic lesions, of course, there are both benign lesions and a malignant lesion that we're going to need to talk about, osteosarcoma. Let's start with the benign anostosis or bone island, a sclerotic lesion in cancellous bone. It often has little spiculated margins and can get relatively big, sometimes called giant when greater than 2 cm. Now, we see these all the time on radiography and CT. Occasionally, the differential diagnosis may include a blastic metastasis if the patient has a known primary prostate, breast, or GU cancer. Workup may appropriately include nuclear medicine, such as bone scanning, in which case there is no substantial increased tracer accumulation. We also see these bone islands all the time on MR, of course, as foci of signal void. So what's the diagnosis here? Multiple punctate foci of low signal intensity are from multiple bone islands in a patient with osteopoikilosis. Here's another example of osteopoikilosis, simply multiple bone islands. Osteopoikilosis is clinically insignificant and should not be confused with metastases. What's the diagnosis here? Osteoid osteoma. The nidus with an osteoid osteoma is small, less than 1.5 cm by definition, and may or may not have central calcification. Often there is an area of dense reactive bone surrounding the nidus. Increasingly, these are treated with CT-guided ablation, as was done here successfully. You know the typical findings of a central nidus with adjacent reactive bone. Here's one more example. Clinically, people talk about aching pain, worse at night, relieved by aspirin. So what's the imaging workup in this case? There's an area of sclerosis here. You might be wanting to know if there's a nidus there. And the single best test to recommend to see a nidus with confidence is a CT scan that shows a small nidus like we see here. What about MRI? Well, what's your diagnosis in this case? It turns out this patient also has an osteoid osteoma. You can see the small nidus, but the adjacent bone marrow edema is often what people focus in on when they get one of these as an unknown case. So just be aware that CT often shows these, the diagnosis more conspicuously and unequivocally than MR, although you can see it on MRI. The differential diagnosis for osteoid osteoma may include a Brody's abscess. What about osteoblastomas? Well, here the nidus is greater than 1.5 cm, and the histology is similar or identical to osteoid osteoma. But unlike osteoid osteoma, with osteoblastomas, the typical target sites are in the spine, posterior elements, and in flat bones like the ribs. Osteoblastomas are often expansile. They may be lytic and/or sclerotic. Here's one that was expansile and sclerotic. Here's another one that was expansile and sclerotic, but this time in the spine, posterior elements, with the characteristic rotoscoliosis. In the spine, here's another example involving the posterior elements, but this time it's expansile and lytic. If you see a lytic lesion in the posterior elements of the spine, some people like remembering the go-ape differential diagnosis. The lytic lesion in the posterior elements may be caused by a giant cell tumor of bone or an osteoblastoma, as we've been talking about. In addition, an ABC, like we see in this image, may cause a lytic expansile lesion in the posterior elements. Plasmacytoma and EG are also in the differential. What about this case? What is the best diagnosis? The best diagnosis is osteosarcoma. So when we talk about the malignant category, we have to talk about osteosarcoma, the second most common primary malignant bone tumor. With osteosarcoma, the most common subtype is the conventional subtype, affecting the metaphyses with permeative bone destruction, like we see here. Often there's a pattern of aggressive periostitis and an adjacent soft tissue mass. What would you recommend as the next imaging test of choice in a case like this? So you get the MR, this is what it looks like. What are you looking to report? Well, the most important thing that the clinicians want to know is about local staging. And among the things they want to know is about the adjacent neurovascular structure. So in this case, as you run the circumference of the lesion, you identify any of the neurovascular structures. And here you can see there's a preserved fat plane between the mass and the neurovascular bundle. So it is not involved. There is no encasement. What else are we looking for in terms of local staging? Well, of course, we're looking for skip lesions. None were present in the femur more proximally in this case. But because with osteosarcoma, mets tend to go to either the lung or the bone, skip lesions should be sought very carefully. In this case, you can see what skip lesions look like radiographically. Osteosarcoma has a bunch of other subtypes that are less common. Telangiectatic osteosarcoma is a particularly aggressive subtype of osteosarc with aggressive osteolysis and minimal or no visible osteoid. How do we make the diagnosis? Well, we can look for hemorrhagic fluid levels in the lesion that are characteristic of telangiectatic osteosarcoma. Some even less common subtypes include the parosteal osteosarcoma subtype, a relatively low-grade type with a relatively good prognosis. It's exophytic and very densely mineralized. Here around the hip, and here an example around the knee. Exophytic and densely mineralized. This is a parosteal osteosarcoma, quite different than the periosteal osteosarcoma, which is extrinsic but has this saucer-like cortical erosion. And the last type to talk about is the secondary type of osteosarcoma, typically occurring in older adults with a risk factor of either Paget's or prior radiation therapy. This patient had radiation for breast CA and now is presenting with a secondary type of osteosarcoma. Moving on to chondroid tumors, we're going to talk about both benign chondroid tumors and the malignant chondrosarcoma. First, the benign enchondroma, a geographic lesion with a narrow zone of transition containing chondroid matrix, with the possible exception of the hand, where chondroid matrix may or may not be present in that lytic lesion. When we see any lytic lesion, including enchondromas in the hand, always look for pathologic fracture. Here, two examples of pathologic fractures through enchondromas in the phalanges of the hand. Besides fractures, the other dreaded complication of enchondromas is dedifferentiation into a chondrosarcoma. Note the cortical breakthrough and large soft tissue mass adjacent to the tibia. What about this case? What's the best diagnosis here? Olliers disease. So, multiple enchondromas are found with both Ollier and Maffucci's syndrome. In both cases, we see the enchondromas as these bizarre chondroid lytic regions that have a columnar configuration and have an increased risk of sarcomatous transformation. With Ollier's disease, like we see here, there are no phleboliths. But with Maffucci syndrome, the multiple enchondromas are associated with soft tissue hemangiomas or low-flow vascular lesions, and we see these focal calcifications representing phleboliths. And Maffucci syndrome is important to know about because it has a particularly high rate of sarcomatous transformation, generally quoted in the literature as 20% or more. Moving on to chondroblastoma, a geographic lytic lesion occurring in the epiphysis of young adults and kids. When you see a lytic lesion in the epiphysis of a kid or young adult, think about chondroblastoma. Here's another chondroblastoma, this time on CT. Note the presence of the chondroid matrix. Moving on to osteochondroma. Typically, these are metaphyseal or metadiaphyseal lesions in which the cortex and marrow are in continuity with the underlying host bone. The cartilage cap should be less than 2 centimeters in thickness in adult. Morphologically, they may be described as having a broad base looking sessile like this, or pedunculated, in which case the osseous excrescence points away from the nearest joint. With multiple hereditary osteochondromas, we can look for bilateral metaphyseal widening, commonly around the knees, shoulders, and hips. Complications can include joint deformities with abnormal range of motion that results, that was present in this patient's ankle. Other complications of osteochondromas that we should look for include fracture. A non-displaced fracture through the base of this osteochondroma was present. And as with any tumor, we need to look carefully at the surrounding neurovascular structure. So in this case, there was actually neurovascular impingement that was causing the patient's symptoms. Finally, impingement may occur upon other bones. In this case, the osteochondroma was impinging on the ischial tuberosity, resulting in ischiofemoral impingement. In all cases, look at the cartilage cap and make sure that it's less than 2 cm, because if it's more than 2 cm, you're going to need to worry about chondrosarcoma, which is the third most common primary malignant bone tumor. So when do we worry about chondrosarcoma as opposed to enchondroma? Well, very importantly, clinically these patients tend to present with pain. But in addition, the lesion size is going to tend to be greater than 4 cm in the axial skeleton or flat bone. We also look for aggressive features of cortical destruction with high-grade thinning of the cortex like we see here. And of course, as we mentioned earlier, looking for a soft tissue mass is also characteristic of chondrosarcoma as opposed to enchondroma. Moving on to fibrous lesions, let's start talking first about fibrous dysplasia, a developmental lesion that typically presents in kids and young adults as a sclerotic and or lucent lesion without any periostitis. Unless, of course, there's a pathologic fracture, in which case there may be some periosteal reaction. Described often as having a ground glass type of matrix, that simply refers to the hazy opacity in a lytic lesion. The bone is weakened, so it may bow. The characteristic shepherd's crook deformity simply describes the varus deformity that can occur in the proximal femur of someone with fibrous dysplasia. One more descriptor that I find helpful is the description of it being a long lesion in a long bone, like we see here. Fibrous dysplasia may affect one or more bones, and when it is polyostotic, we think about the triad of McCune-Albright that includes not only polyostotic fibrous dysplasia, but also the coast of Maine type of Calfeo lay spots and precocious puberty. On bone scan, there's intense increased tracer accumulation. Moving on to the fibroxanthoma, or non-ossifying fibroma, or fibrous cortical defect. These are the most common bone lesions. They typically occur under the age of 30, and we talk about non-ossifying fibromas if less than 2 cm, fibrous cortical defects if greater than 2 cm, although both are identical histologically. These classically occur in the metaphyses in an eccentric location, have sclerotic margins, and are don't-touch lesions. Moving on to vascular tumors, benign and malignant. First, starting with the benign hemangioma, like we see here. Hemangiomas, as we all know, are benign proliferations of vascular channels that are commonly seen in the spine, and we look for these areas of coarse trabeculation, both on radiography and CT, like we see here. On MR, we can see the fat overgrowth between those areas of prominent trabeculation displayed as high T1 signal intensity. Glomus tumors are much less common and occur in the distal or acral skeleton. Arising from the neuromyoarterial glomus, we see on radiography these sharply marginated eccentric erosions classically in the distal phalanx because there's an adjacent soft tissue mass like we see here. These enhance avidly after contrast administration because they're very vascular. So MR of a glomus tumor. What about this case? This is an aneurysmal bone cyst. ABCs are considered reactive vascular processes that may be associated with prior trauma or with certain types of tumor that we've discussed. Aneurysmal bone cysts are, as the name would imply, aneurysmal or expansile, and there's a rim of intact cortex or periosteum. They do have well-defined margins. So here's the way it looks in the axial plane. Note the fluid levels and relatively little central contrast enhancement. The differential diagnosis of fluid levels within a lesion not only includes telangiectatic osteosarcoma that we talked about, but also ABC and some other lesions associated with ABCs. So it's not entirely specific, but often it's associated with bleeding into the lesion or a pathologic fracture through a lytic lesion. Moving on to marrow tumors, namely malignant tumors in the form of myeloma, which is the most common primary skeletal malignancy in which malignant plasma cells replace normal marrow. Multiple myeloma typically presents in adults over the age of 40 in areas where there's red marrow, like the skeleton, like in the skull, rather than in the distal skeleton. And of course, we look for multiple small punched out lytic lesions with multiple myeloma, like we see here in this case. Plasmacytoma is simply myeloma at a single site, and patients typically develop multiple myeloma within 5 years. The appearance of this on imaging is often rather nonspecific. We see a lytic expansile lesion presenting with a pathologic fracture, but no internal matrix. A couple benign lesions to talk about. Let's start with the solitary bone cyst or unicameral bone cyst. It is a true bone cyst found typically in kids as a lytic lesion with a narrow zone of transition and relatively mild expansion. It usually targets the metadiaphysis and is located centrally in the medullary canal without periostitis, unless, of course, there's a fracture, in which case we look for the, some would say, pathognomonic fallen fragment sign. Here's a patient who had a fracture with a fallen fragment sign, and you can see that as the years pass, this heals and it fills in with an area of sclerosis. 3 more cases of solitary bone cyst, each with a pathologic fracture, to give you an idea of the spectrum of appearances. Moving on to giant cell tumor, composed of osteoclastic giant cells, hence its name. We see these characteristic findings in skeletally mature patients. Namely, there's an eccentric lytic lesion that's located in a subarticular location with a non-sclerotic margin and a narrow zone of transition. The most common site for giant cell tumor of bone is adjacent to the knee, like we see here in the fibula. But the second most common site is adjacent to the wrist, and that's worth knowing about. Moving on to Ewing sarcoma, the second most common primary malignant tumor of bone in kids. It's one of those small round blue cell tumors like LCH and osteomyelitis. Of course, it's an aggressive lesion, and when it affects long bones, it affects the diaphysis and has an age peak of 10 to 15 years with a large adjacent soft tissue mass, as you can see here. But what about this case? A 24-year-old male. There's a large soft tissue mass adjacent to this flat bone. The flat bone, the scapula, does not look normal. And there's no osteoid or other discernible matrix. This was a case of Ewing sarcoma. Note the markedly increased PET avidity. Now, what about this case? A 74-year-old, not a 24-year-old, with a destructive lesion involving the scapula. This case is an example of lymphoma of bone. Finally, we'll mention metastases, which in adults are at least 25 to 100 times more common than primary malignant bone tumors. When they present, they're usually polyostotic, and usually it targets the central skeleton proximal to the elbow and knee and spares the distal skeleton that is fatty replaced. Most commonly, when we see a lytic lesion, we think about primaries coming from lung, kidney, and breast, like this classic pathologic fracture in the lesser trochanter. When we see a blastic lesion, it often comes from a primary prostate, breast, or GU primary, like with this ivory vertebral body.